Well, welcome everyone. I'll kick it off. My name is Kenley Money. I'm the Arkansas APCD Director at the Arkansas Center for Health Improvement. I know that we have some new folk on the phone and some experienced folk on the phone. So let me kick it off with a bit of an introduction. Welcome to the July 2022 quarterly Arkansas APCD Data Users Group. It's our 12th users group session. We're all a little nostalgic, 12 so far. We've been doing this a minute. For those of you who are new to these sessions, the Arkansas APCD is part of the Arkansas Healthcare Transparency Initiative, the ACHI, and is administered by the Arkansas Center for Health Improvement, or ACHI. We call it ACHI. The Arkansas APCD is comprised of private carrier and public payer medical, pharmacy, and dental claims, as well as enrollment data and provider data. Additionally, the HTI enables the use of key data sets from the Arkansas Department of Health, including Arkansas Vital Statistics data, hospital discharge data, and emergency department data for self-pay and the uninsured, cancer registry data, and medical marijuana card holder data, excuse me. We have some Arkansas workers' compensation data as well. So I hope that you find today's session helpful. Some housekeeping before we move forward. Feel free to type your questions in the chat at any time and we'll address them as we can. At the end of today's session, we'll provide a link to our service desk application where you can enter any question that didn't get addressed or topic you're interested in discussing. The Arkansas APCD data can be complicated. You can also request time with our team to address specific questions you may have about how to use and interpret the data. We are here to help you. The link to this deck and recording will be provided in a follow-up email that you will receive at the conclusion of this session. And finally, the next Data Users Group session is scheduled for October 26, 2022. We hold these quarterly. So with that, let's go to the next slide. I'm going to take my video off so we can focus on the deck. Our agenda today, we develop our agenda using data user input. If you have any ideas for topics, please let us know, either by entering the ideas or questions in the chat or by emailing us. Perhaps they'll be on a future Data Users Group agenda. So we have, as you see, a featured speaker today, Dr. Maria Steenland. Then we're going to talk about our work with colorectal cancer in Arkansas, a versioning refresh, and for the new folk, we'll explain what that is. Some data user questions from other APCDs and the latest APCD release information and data tips and questions and discussion if possible. We have a big agenda today, so we will use our time wisely. Next slide. Presenters are me. I introduced myself already, Kenley Money, with ACHI, Dr. Steenland, and then Craig Wilson, Director of Health Policy here at ACHI. Next slide. So I would like to introduce you to Dr. Maria Steenland. Let's go to the next slide, Kathy. I admit to some plagiarism here. This seemed to be the best way to describe it. Dr. Steenland is a health services and health policy researcher focused on maternal and reproductive health policy in the United States. Her research uses econometric methods to evaluate maternal and reproductive health programs and policies with a particular focus on Medicaid policy. She will share with us today her project executed using Arkansas APCD data. She was one of our first data users and has done a great job with her project and is published. She can talk about that. Dr. Steenland will manage her slides, so if you'll bear with us for a moment, Kathy, our project manager, will make her the presenter.
Try to share now, Maria. If you can't, I can do one other thing.
Let me see. I don't see. Oh, here we go. Here we go. Okay.
Great.
So do you see like my slides without any notes or anything like that?
Yes.
Great. Okay, well, I'll just get started then. So as Kinley mentioned, I started using the Arkansas APCD, gosh, I don't know, several years ago to work on this project, and I have an upcoming, a second manuscript that I'm almost finished with. So this paper was finished about a year ago and then published, I think, sometime last winter, yeah, or early spring of this year. So this is a study that I worked on with Arnold Trivedi, Ira Wilson, and Kristen Madison. And it looked at the effect of Medicaid expansion on postpartum health insurance coverage and postpartum outpatient care use in Arkansas. I will start off talking a little bit about the study motivation, even though this is a data users group. So I'm happy to talk more about the data, any further data questions later. But so the maternal mortality rate in the United States is much higher than the maternal mortality rate in other similarly wealthy countries, such as the UK, Canada, and France. And this difference is really driven by the high mortality rate among Black women as compared to Hispanic women and non-Hispanic women in the US. And I think there's a popular perception that most maternal death takes place like during the actual childbirth experience, but in fact, just over half of maternal deaths take place between 1 day and 1 year postpartum. And 12% of deaths take place as late as after 6 weeks postpartum. Expert medical groups across states in the United States carefully have reviewed maternal deaths, and they estimate that 60% of postpartum maternal death is preventable through things like improved diagnosis, use of more effective treatment, and coordination of care between healthcare providers. So despite the importance of the postpartum period and postpartum healthcare, the months after childbirth in the United States have historically been a time when many people lose health insurance coverage altogether or experience gaps in health insurance coverage. And this is particularly true for people whose pregnancy care and childbirth care was paid for by Medicaid. On average in the US, pregnant people with income up to 185% of the federal poverty level are eligible for Medicaid during pregnancy. But people who qualify for Medicaid pregnancy coverage lose that coverage at 60 days following childbirth. After 60 days, postpartum people are eligible for Medicaid through a parental eligibility pathway, which was, set at 138% of the federal poverty level after the ACA in 2014 through Medicaid expansion in expansion states, but was on average and remains on average much lower in states that didn't expand Medicaid. So nationally, Medicaid expansion increased postpartum insurance by around 10 percentage points among low-income individuals. But still now, and certainly when we started this work, there is less evidence on the effect of expansion on postpartum healthcare use and postpartum health outcomes, and in particular on racial disparities in postpartum healthcare use. So in this study, what we tried to do was to add to this literature by focusing on the effect of Medicaid expansion in Arkansas. As most people here may already know, Arkansas expanded Medicaid coverage under the Affordable Care Act on January 1st, 2014 through a private option, which enrolled newly eligible beneficiaries in marketplace plans. And Medicaid expansion in Arkansas increased income eligibility for parents from 16% of the federal poverty level in 2013 to 138% in 2014. So just like a massive increase in income eligibility. We were interested in this study in examining the effect of Arkansas's Medicaid expansion on the continuity of postpartum health insurance during the 6 months postpartum, and also on the effect of Arkansas's Medicaid expansion on outpatient healthcare visits during the first 6 months postpartum. We also examined the effect of expansion on these outcomes separately among non-Hispanic Black and non-Hispanic white women. And then finally, we were interested in comparing directly population level racial disparities in these outcomes before and after Medicaid expansion to examine descriptively how racial disparities in coverage and care changed during the study period. So in this study, now we're getting into more of the APCD data stuff, we use birth certificate records, which, as Kenley mentioned, are part of what is possible to be offered among the vital statistics are birth certificate records. So we use birth certificate records in Arkansas from between 2013 and 2015, and we linked those records to all payers claims data from 2013 through 2016. And we did this using the APCD's individual ID to track both enrollment and healthcare use over the 6 months postpartum, which importantly would allow us to observe any insurance enrollment or outpatient visits, regardless of whether the postpartum person switched between Medicaid and a commercial payer or between commercial payers, so long as that commercial payer was available or represented in the APCD. So we use this linked data to create outcomes for continuous health insurance coverage during the full 6 months postpartum. And important to note that the 6 months postpartum period covers the time period before and after 60 days when people had historically often lost Medicaid coverage. We also created a variable for the number of outpatient visits during the first 6 months postpartum. And because we expected that most of or any change in visits due to Medicaid expansion would be mainly concentrated after 60 days postpartum, we also created separate variables for visits between 1 and 60 days postpartum and visits between 61 days and 6 months postpartum. In this study, we used what's called a difference in differences analytic strategy. And basically what difference in differences does is it compares the change in your study outcome in what you consider to be a treated group over the study period with the change in that same outcome in your non-treated group over the study period. So in our case, we considered women with a Medicaid financed childbirth to be in the treated group. And that's because to be eligible for Medicaid pregnancy coverage in Arkansas, you had to have income under 200% of the federal poverty level, which means that most people who had Medicaid pregnancy coverage were likely to be eligible for parental Medicaid under expanded Medicaid expansion. We included women with commercially financed childbirth in the control group. And similarly, we did this because these women were unlikely to be eligible for parental Medicaid due to their income level after expansion. So this diagram is meant to show how we classified exposure to the policy in our analysis. Births between January and June 2013 were considered unexposed because for all those women, the full 6 months postpartum took place before the start of Medicaid expansion in January 2014. And this is what we consider to be the pre-period. Births between July and December were considered to be in a transitional period and were excluded from the analysis because the 6 months postpartum for people with births in this period overlapped with both the pre and the post-expansion periods. And births in 2014 and 2015 were included in the post-period. So I'm going to move on to talking about the study results. This figure plots the share of people who gave birth in each study quarter who had continuous insurance coverage for the entire 6 months after childbirth. The red line shows this percentage for people whose childbirth care was paid for by Medicaid, and the blue line shows the percentage for people whose childbirth care was paid for by a commercial payer. So for people with a Medicaid paid birth, approximately 50% had continuous 6 months coverage after childbirth before Medicaid expansion. And this percentage increased very dramatically after the start of Medicaid expansion in 2014. For people with a commercially paid birth, around 90% had continuous 6 month postpartum insurance coverage, and this percentage remained relatively stable throughout the study period. So looking at the actual difference in differences regression results, what we find is that people with a Medicaid financed childbirth had a 29 percentage point increase in continuous 6 month postpartum insurance coverage after Medicaid expansion, whereas people with a commercially financed childbirth had no statistically significant change in their continuous coverage. And this gave us an estimate, an adjusted difference in differences estimate effect for this outcome of a 28 percentage point increase in continuous postpartum health insurance coverage. So this figure plots the average number of non-emergency department outpatient visits for people with births in each quarter of the study period over the 6 months postpartum. So here again, average visit numbers for births that were paid for by Medicaid are plotted in red, and average visit numbers for births that were paid for by commercial payer are plotted in blue. So I guess you can see I didn't write this out in my notes, but you can see visually that the average number of visits in the 6 months postpartum didn't change a lot over the study period for commercially paid births, but did increase after Medicaid expansion, particularly after July 2014 for people who had a Medicaid paid birth. So for the difference in differences outcome, estimates for this outcome are that for people with Medicaid financed birth, there was about a 0.8 visit increase comparing the pre-expansion and the post-expansion period. But there was no statistically significant change in average visits for in the commercial group after Medicaid expansion. So this gave us an estimate of a 0.9 visit increase, or almost a 1 visit increase during the 6 months postpartum due to Medicaid expansion. So when we split visits between visits taking place during the first 60 days postpartum and visits taking place between 61 days and 6 months postpartum, we found that, well, as we expected, that the change in visits was really concentrated between 61 days and 6 months, the period during which, prior to Medicaid expansion, many people lost health insurance coverage. So these are the results from analysis stratified by race. The figure on the left shows the difference in differences coefficients for non-Hispanic white and non-Hispanic Black individuals for the postpartum coverage outcome, and the figure on the right shows the difference in differences outcomes by group for the postpartum visit outcome. And we find that the magnitude or the size of the change, the size of the effect of Medicaid expansion for both outcomes was relatively similar for non-Hispanic Black and non-Hispanic white individuals. So finally, when we combine people with Medicaid and commercially paid childbirths to look at the population, the full population of births, and compare racial disparities before and after Medicaid expansion, we find that before expansion, the share of Black women with continuous 6-month insurance coverage was lower than that for white women, and that after expansion, the racial disparity in 6-month insurance coverage was completely eliminated. When we do the same comparison for postpartum visits, we find that Black women had fewer visits before Medicaid expansion on average. And after expansion, there remained a racial disparity in postpartum visits. So more broadly, what these results tell us is that uninsurance after childbirth was an important driver of differences in healthcare use between people with commercially and Medicaid paid births before Medicaid expansion. I think this study also has policy relevance to what are called the 12-month pregnancy Medicaid extensions, which are being implemented in a lot of states currently. And these results have really implied that these 12-month extensions, should they be implemented in non-expansion states, which some non-expansion states are implementing them, are likely to accomplish similar gains in insurance coverage and care. But the results also indicate that increased coverage is really not sufficient to reduce racial disparities in outpatient postpartum care. So while healthcare coverage is a necessary part of improving maternal health care, reducing racial disparities in care use and outcomes may require doing additional things like improving the quality of care by ensuring that care is respectful, patient-centered, and culturally competent, and by improving people's ability to access that care through things like paid leave from work, childcare, and improved transportation options. And that's all I have to share today. Thank you.
That's terrific. Thank you, Maria. Does anybody have any questions at this time? And just to reiterate, if you don't now, that's fine. We feel free to put questions in the chat for later or send them to us via email. We'll provide a link at the end of the presentation. So here's one. How did the number of ER visits change?
Yeah, so in our outpatient, I didn't like state this so many times, so it may not have been clear, but our outpatient care measure did not include ER visits. We were interested in ER visits. Let me see if I can stop this share. We were interested in ER visits, but and we're also interested in hospitalizations, like readmissions, postpartum readmissions. But in the end, the number of those visits was relatively low, and that led to difficulties in our like statistical power to look at those outcomes. So that's why we ended up focusing on just outpatient visits. So I actually don't have the answer in ER visits, although I know that is like the sort of often, you know, next step and next outcome that people are interested in. We just, you know, we were looking at all births, but there's not that many births in Arkansas. And also we weren't able to include all births because, you know, there's some commercial payers that aren't included in the APCD. And so we only included births where we were able to identify the type of payer during childbirth, which basically limited us to Medicaid and those commercial births that were or those commercial payers that were included in the APCD. So we weren't even able to include all the births in Arkansas. So that's a limitation for sure of our study, is that we didn't have statistical power to look at less common outcomes like emergency department visits and hospitalizations.
There's one more question before we move on to our next topic. Did you measure race, ethnicity from birth certificates or from the member enrollment data, or both? That's
a good question. I think it was from birth certificate data. Yes. But I guess I didn't even know it was in the enrollment data. Maybe it is. No. I should have also checked there too.
It is not. I'll interject and say there is some race ethnicity data in the commercial, the fully insured enrollment data, but not much. Many carriers don't collect that information. So the appropriate thing to do is to take it from the birth certificate data. We're trying to improve that. We're working on getting more data from the carriers, where it's possible. Well, Maria, thank you very much. We really appreciate it. And I would expect.
Thank you for the opportunity.
Yes, yes. We love seeing our data used and published. All right, well then, why don't we move on to our next topic, which is about colorectal cancer in Arkansas. And so Craig, you're pretty sneaky because I had a photograph of you that we don't have to see now. Our next speaker is Craig Wilson, Director of Health Policy at ACHI, and I'll just turn it over to you, sir.
All right, can you see my slides all right? Is it showing properly?
Yes.
Okay. Good deal. It's always good to hear Dr. Steenland present on her work with the APCD. This will be less, I would say, much less researchy. This is kind of one of the things that we do on a kind of fast track to engage with policymakers, and this is actually an assessment that has actually been very successful in moving policymakers toward change in Arkansas and ultimately beyond. So we wanted to look really and Fight Colorectal Cancer, which is the national advocacy organization, really came to us as a state, knowing that we had very much an investment in the state's all-payer claims database and wanted to really work with us to do this assessment on colorectal cancer screening here in Arkansas. Let's see if that'll move. There we go. So let me talk first about the purpose of the assessment. One, we wanted to generally identify any gaps in colorectal cancer screenings, primarily with the non-invasive tests You may know that there are kind of a couple of different ways to go about colorectal cancer screening. There's been the development of several different types of non-invasive screenings that you can do from your home, or as was the case for me this year when I turned 45, I just went and got a colonoscopy so that if there were polyps there, those could be removed, because with a non-invasive screen, it's either positive or negative. And you don't know really whether you have polyps there. So I went ahead and got a colonoscopy. But really, from the Fight Colorectal Cancer standpoint, they wanted to do two things with this assessment. One, they wanted to move in line with anticipated at the time, and ultimately it came through while we were doing the assessment, but new USPSTF, which is a Preventive Services Task Force at the federal level, guidelines to lower the age of screening for average risk patients from 50 to 45, and to get in place a law here that would require private insurers and Medicaid to cover it at that age. But then also there have been some issues with coding a follow-up colonoscopy after a non-invasive screen as a diagnostic colonoscopy, as opposed to a completion of screening colonoscopy. And so they wanted to examine whether individuals who had a non-invasive screen ultimately had cost sharing associated with that follow-up colonoscopy to get a law in place that would remove that financial barrier. So we did a number of different assessments, and you can only do so much with claims, right? We didn't have the outcome of the non-invasive screen. So we kind of relied upon an assumption in the claims information that was, if a person got a colonoscopy within 6 months after a non-invasive screen, we made an assumption that that was a follow-up colonoscopy. Now, we know that some, may not have, that was one of the reasons for the policy change, right? Some may not have gone to get a follow-up colonoscopy, even after a positive screen, due to a financial barrier. Or some may have gotten that follow-up colonoscopy outside of that range. But we just made an executive decision that 6 months was a good time frame to give some leeway for scheduling an appointment and things of that nature. But that was just kind of an assumption that we made. So we wanted to look at, the people who got a non-invasive screen based on a claim. And we also looked at those individuals if they had a follow-up colonoscopy, then did they have a copay? And then we also looked in the Department of Health's cancer registry data to see just generally for people who were diagnosed with colorectal cancer, at what stage were they diagnosed with that. And then we kind of made some assumptions about the behavior of 50 to 54-year-olds, and then kind of applied that the screening rate in that range to say this would be the expected number of people who might receive a non-invasive screen, and the people who would have a follow-up colonoscopy, to just kind of put an Arkansas-based number on what this policy change might mean. Okay, and then really our goal was not just to do this for Arkansas, but to provide guidance for other states, including just the blueprint, the analytical blueprint that they could just go and execute in another state that had an APCD or access to some type of claims, to be able to do the same type of assessment for every state in the nation if they so decided to. And then we created an advocacy piece and some guidelines to help other states. So let me jump right in. Our data sources are, of course, as I mentioned, the APCD. We had some differing time frames in there just due to data lag. That's always the case with the registry data and with Medicare data. And of course, with colorectal screenings, of course, we had to look at Medicare data for this analysis. So our findings, and I don't really worry about that second year. We were only able to do a half a year because the Medicare data was cut. We didn't have Medicare data for the second half of the year at the time. So that's why we had to cut it off. And so that you can assume that it's going to be roughly the same percent for the full year, right? We've got a half year there with non-invasive screenings for 2017 and 2018, 2017 being 5% of the population in that 50 to 75 age range that were screened through the non-invasive pathway. And then we looked at ages 50 to 54. As we expected, a smaller percent of people were screened in that age range, because at the time for 2017, that was the starting age range for getting screened. And many people are not aware they're supposed to be screened at that age. And so that's what you would have expected, a smaller percent of people in that age range being screened. So then we went to, this is just a look by payer source. It's not really some differentiation there. Commercial population screening higher in 2017. We don't really understand why the screening went up in 2018. We don't, there might be some environmental influences. Maybe there were in the Medicaid expansion population and the qualified health plans. Maybe there was some additional focus by providers or some type of quality metric that the payers were incentivizing folks to screen. Also, we do know at the time that Cologuard was being much more heavily advertised on television. So that could also be the case, that screenings went up from a non-invasive standpoint at that time, but really not much of a change from year to year, except in that expansion population. Get back over here. And then when we went to the percent of those individuals, so this is of the individuals who had a non-invasive screen, about 12% really across the board had it, and that includes in the 50 to 54 age range, had a follow-up colonoscopy. That is, remember, that is within 6 months that we tested that. And so of those individuals who had a follow-up colonoscopy, this is the, wait a minute. So I don't know why I had that. Oh, so this is the payer breakdown. So individuals with a follow-up colonoscopy, a higher percent, just slightly, in the Medicaid expansion population. That would, perhaps be the case, given that these are lower income folks, more susceptible to having colorectal cancer. And then the percent of the people in the 50 to 75 age range who had a follow-up colonoscopy and had out-of-pocket costs, whether that's cost sharing or co-payment or co-insurance. And you can see here that for, this is kind of the big hitter right here. For all of those individuals who had a follow-up colonoscopy in that age range, the 50 to 75, about 3/5, about 62% in both years had some type of financial exposure. In the 50 to 54 age range, it was much lower there. We don't really know the reason for that. But this is kind of our big hitter from a policymaking standpoint. When you can say 3 out of 5 people had some cost sharing exposure for a follow-up colonoscopy that they really needed because they likely had a non-invasive screen that was positive. That's what really gets policymakers interested in this, when you can show something like that. This is by payer, so you can see that Medicaid proper and the Medicaid expansion population, those folks had much less financial exposure that could have resulted in the higher percent for follow-up colonoscopy than in the commercial sector there, about which roughly half of the population had financial exposure. So then this gets to our assessment of anybody who was 45 and up, who was diagnosed. This is by stage of cancer. This is not by stage of cancer. So this is by age group. I'll get to the by stage here in a minute. But you can see this goes to the point of lowering that age to 45. You can see that there were 85 people in 2016 and 79 people in 2017 who were diagnosed in that age range of 45 to 49. Now, we don't know whether or not they were of average risk. We don't know whether or not they had any family history or anything, but still we can point to a number and say, look, 85 people in 2016 were diagnosed in the 45 to 49 age range. So it gives some evidence toward lowering that age range, or at least requiring it. Most of the population who were diagnosed were in those upper age ranges. So then this is by stage. So for those individuals who were diagnosed in that 45 to 49 age range, so this is advanced. Yeah, so the percent of the population diagnosed in the advanced range, and you can see that a lot more who were diagnosed in the 45 to 49 age range were diagnosed at advanced stage. So that's an important piece of the policy angle as well. And generally, anybody who was diagnosed, they were more likely to be diagnosed at an advanced stage than not. So that just goes to the importance of screening at earlier ages and the frequency at which you screen. And by the way, so colorectal cancer is actually estimated to be the #1 cancer killer for men and women by 2030 for the age range of 20 to 39. So there's more incidence of colorectal cancer at younger ages than there has been previously. So researchers are, of course, looking at that. So this then goes to kind of our policy piece, which is kind of what my angle is. I don't do any of the analytics. I don't really do any of the data, but turning this information into something that's digestible for policymakers is what my team does. So then, this just kind of makes the case for and provides context for where we are as a state in terms of colorectal cancer, 5th highest rate of colorectal cancer in the U.S., 8th highest death rate in the U.S. We showed the trends there. We show differences by race and by gender or by sex, and then the percent of using our own data that we analyzed, showing that percent of late stage cancer diagnoses. And then we talk about the changes in the recommendations and the potential for how many people might be screened if we implement this across the board. So giving really Arkansas specific numbers for the number of people who could potentially be screened and helped as a result of this policy change. And then talking about how some of the what some of the other states have done and how they've implemented these new requirements. So saying we won't be the only state to have done this. Texas and Rhode Island have already done this. So saying, we won't be right out of the gate to do this, but we don't want to be last in doing this as well. And then the really big hitter, why this is important, because people face financial barriers. And that's one of the reasons that they don't get a follow-up colonoscopy, because of the cost. And then kind of what might be the impact associated with such a policy change. So then this just goes into some of the state and federal law guidance. We did make a state law-based change, lowering the age and requiring protection from cost sharing for follow-up colonoscopies. That requirement began January 1st of this year. The Fight Colorectal Cancer folks have really been doing a wonderful advocacy job at the federal level. They got the Department of Labor and Health and Human Services to issue guidance that would apply to Medicaid and Medicare this year, as well as self-funded plans governed by the federal law under ERISA. So really broad-based kind of new requirements on health plans to cover this and to protect people from cost sharing for follow-up colonoscopies. That's just kind of the language that it's an integral part of the preventive screening, without which the screening would not be complete. So that was the language in there. It's about completion of screening, not a separate part of screening and going into diagnosis. That's all I have. I tried to go through that very fast. We did actually do some race and demographic analyses. Of course, as was the case with what Dr. Steenland said, you run into some issues with those fields being complete and being able to trust the data enough to really make some true findings on that. We did do that. There were some differences in rural, but really, frankly, not much of a difference in race, although we would have expected that. So that's it for me.
Thank you, Craig. Thank you very much. We probably have time for one question, maybe two, if anybody. No? Well, again, enter your question in the chat or send us an email and Craig will be happy to respond. So Kathy, why don't we go to the next slide? Oh, there's the photograph.
Oh.
Craig was recently awarded with the Delta Population Health Institute Excellence in Policy Award for his contributions to population health and health equity in the Mississippi Delta region. Congratulations, Craig.
Thank you.
And thank you, Kathy. All right, let's go to the next one. All right. In our time remaining, the versioning refresh. So over the past few months, the Arkansas APCD team addressed a number of versioning questions for and with data users. So we thought we'd provide a very short primer. This is kind of a complicated subject, so let's go for it. For those of you who are new to this or not terribly experienced yet, haven't used the data much, the term versioning is an APCD term used to represent claim updating or adjudication. The Arkansas APCD mandate requires that submitters provide final paid claims. That's pretty clean. However, changes do occur, and approximately 1% of claims, whether they be medical, pharmacy, or dental, are updated each year when things happen. Sometimes a payment amount changes or a date changes. And the Arkansas APCD has implemented versioning, quote, processes to manage these changes. They worked with each of the submitters to understand how their claims may change and how to group these records and determine the latest record for use in analytics. So next slide, please. Usually, data provided to data users, are already versioned and should require no further processing to determine usable records. We are taking care of that for you. However, some exceptions exist, unfortunately, and the scenarios are, so there are claims data from submitter systems that have no processes to provide updated records. Yes, it's true, it's hard to believe, but there are some systems from which we get data from carriers that can't tell us when a changed record comes through. They can't. The second bullet, claims data from submitter systems that change their versioning approaches without telling us. That has happened. We have a data tip that we're going to talk about in a couple of minutes. That very thing happened. Claims overlap between submitters, TPAs and PBMs, previously unknown or unidentified by the submitter or our team. We have a data tip about that as an example. And whenever these occur, additional processing may be required to determine best records to use in these cases. But remember, only about 1% of the claims are versioned. So, however, because you work so closely with the data, you may see claim groups that seem like they're not, and you have questions. Hopefully, we'll be able to help you a little bit with this, but remember, you may always contact us for help. If you see something that looks odd, you can't tell the difference, why did these claims come together? Call us and we'll work it through. Next slide, please. So how to identify what these, if you see something weird, how do you know that it could be problematic or may be problematic? So generally what we've seen is that the data user groups data on key fields to understand cost or utilization or whatever the answer is. The question is they're trying to answer, and the grouping can be on service date, fill dates, provider names, drug names, procedure codes, whatever. And when that happens, you may see claim records that appear to have duplicated values in the key fields, but have a different claim number. And one of our data tips is about an overlap between Medicare fee-for-service data and some commercial claims from Aetna. Not everyone gets Medicare, but this particular data user did, and it was interesting. Or the next one is claim lines. Well, let me stop and say the claim number are the fields listed there, MC004, PC004, and DC004. And you might recall that a claim can have multiple data rows, each row with the same claim number, but each row is differentiated by the claim line. So the next bullet there, claim lines, MC005, PC, DC, appear to have the duplicated values in the key fields, but have the same claim number. So you could have two rows that say claim number 123 with line 2. Again, these don't happen often, hardly at all, but you may see it. So what do you do? Next slide, please. Excuse me. I should also add that the older the claim, the less likely this will happen, if it happens at all. So what we'd like for you to do is to call us. But if you are still doing some forensics to determine what's going on, you can group, when you find these groups that look like they may be one of the situations that I described, you can look at the claim status field on these records, and the claim status field is noted as MC138, PC110, and DC059. And these fields, the values in these fields are used in versioning rules in our systems to determine which is the latest record, the one that should be used. And the table on the right has the values that we use and what they are, and they seem pretty easy to understand. Clearly, the original one is the first one, and then if it's a back out or a delete or a drop. But in this situation, if you have two claim lines, say, and one says O for original and the other says A for adjusted, in one of these scenarios, these very rare but weird scenarios, then you would use the A because it's the second one. The later one, this claim was adjusted. If it's still strange and still, I'll answer that in just a moment. If it's still strange and it's still ambiguous, then use the paid date, the latest paid date. And that, when I see these, the paid date is the best differentiator. And you can see it in the claim when they group like that on those key fields. Most often the paid date's different, and the one to keep is the later one. And sometimes you can use service dates. MC059 is the procedure service date on the medical claim. PC032 is the fill date on the pharmacy claim. DC035 is the service date on the dental claim. So again, when you find situations like this, do not hesitate to contact us, because it could be a situation where the submitter has changed their protocol and didn't tell us, so that we can reach back to them and work out the new versioning rules. So, all right. The question in the chat was, are there timestamps? No, there are no timestamps on these data, but the paid date is the solid proxy for that. All right, let's go to the next. Oh, did I get, that's the one question. Yeah, okay. Next one. Questions from other APCDs. We started adding this section a couple of sessions ago. It's always interesting to know what other all-payer claims databases are doing. And this time I selected something from Oregon and from Massachusetts. I do a lot of Massachusetts. They're a very mature APCD, and they have lots of examples. In this example, while it's not necessarily coding or data tips, it it related to us because some of our data users utilize hospital discharge data, either from the Arkansas Department of Health or ACHI. And this list was compiled by Oregon, could be helpful in detailing the differences between these two data sets. And as I said before, although Oregon put it together, it applies to us. But you can see, I don't want to read all of these to you, but like, except for like this one, APCD contains payments, whereas hospital discharge data contains charges. There are some key differences that are important to know as you use these data either separately or together in your analytic projects. Next one. Massachusetts had this one up. I thought it was interesting because it was about acupuncture, alternative medical procedures. The question there was from Massachusetts, though I used the Arkansas APCD data to answer it. So the top three in Arkansas are these three procedure codes and what they mean. I found that it's in the claims, so there is information if your analytics include or require alternative medical procedures like acupuncture. I urge all of you to go to other APCDs to look at what they're doing and see if they have any methodology or ideas or whatever extra information that would be helpful to you. Next slide. Okay, well, we'll hurry on. So latest release information. The current data is from January 1/13 to June 30, 2021. These links take you to very valuable data resources. If you have not used these, I highly encourage you to do so. The document noted in the blue box is the attributes deck. That will help you. Maria talked about that there's some restrictions. Not all the commercial data is in our APCD. This document can help you understand that. We're happy to go over that. It's on the website. Please ask if you need to. For the sake of time, we're not going to go to each of these links except for the next slide, Kathy. Data tips. This is your most valuable tool as a data user, the data tips. We send out a monthly email with the latest data tips or data tips that are older but should be front of mind. So if you have not put your email address on that list, please let us know. We'll add you to it. When you go to our data tips website, you'll see this red box, new data tips and issues, and click on it. It'll take you to the latest ones that were either added or changed in the past 30 days. Very, very helpful. Read your data tips. Now I want to go over the latest three. Next. This is one of the tips I mentioned a little while ago about that applies to the versioning issue. So Aetna identified a potential issue within pharmacy claims for these entities. And I will tell you the genesis of this was a data user who had groups of claims that, as I recall, they had different claim numbers, and they called us and said, what is going on? This looks like the same prescription. It's the same drug, it's the same pharmacy, it's the same provider, it's the same date, but it's different. There are different claim numbers. What's the deal? So we reached out to Aetna because that was the submitter, and they said some pharmacy claims for these entities contain the same information but different claim numbers. They are called intraday reversals. The claim comes in and is backed out the same day for various reasons. Since the pharmacy is point of sale, this may occur in the same day. If you click on this link and go to our data tips, the workaround is outlined in the data tip. So this is an example of one of those hard to find versioning nuances that, of course, someone found. Next slide, please. Okay, another data user found this, and this was a surprise to us because we were unaware at the time. It's not really an issue because there's not a resolution from the carrier that we can fix this. If you get Medicare data, not everybody can, but if you do, this will be important for you, that we found that some Medicare fee-for-service claims overlap with Medicare Advantage claims from the private carriers. So These were discovered when the data user grouped on those key fields, and there were different submitters, Medicare and the commercial plan. I can't remember which one, but there is, if you go to this data tip, the identification rules and the workaround are in the data tip. If you experience this crossing Medicare and commercial claims, that's what you do. So please be aware. All right, next data tip. Caremark or CVS member IDs with multiple dates of births and gender. Newly identified data quality issues have been found affecting approximately 4% of the Caremark CVS member records. In some instances, a member ID is used for more than one member associated with a subscriber. These member IDs have multiple dates of birth. There is, et cetera, et cetera. There is a workaround in the data tip, and we are working with Caremark to determine if we can fix it. So be aware of these data tips. They are the top 3 that I wanted to share with you today. Next slide. Can't say this enough. Check your data tips. And I should add a slide that says call us if you have any questions, or send us an email and we'll set something up. Okay. This is, reach out to us at this email address for the questions that I've urged you to send to us. Data use, data request, pricing. This is the best way to reach the Arkansas APCD team. Does anyone have any, well, here's our call to action. Next data users group meeting, October 26th. Next slide. Any questions, anybody? With 1 minute to spare. No? Well, again, thank you so much for joining us today. Reach out to us, ask us questions. We want to make this data more usable, and we can't do it without you. We mine the data, we work with our analytics team, and we're always looking for ways to make it easier and better and more understanding. And for those of you who are new, if you want some more context about what's in the APCD, reach out to us. We'll set something up. It wouldn't hurt us to have an APCD primer periodically. So thank you very much and have a great day. Stay cool.